Welcome back, everybody, to another episode of Teens No Cap. I'm your host, Charity Chaffee. I'm a licensed mental health counselor in the state of Massachusetts, and this entire podcast is all based on teens and treatment. So if you are a clinician working with teenagers, or you are a parent in the thick of working with your teenager and parenting one, please join us because we have so much fun content coming up. But today, we are joined by a very special guest that I recently met at a conference, and I will let her introduce herself in a second. But today we have Laura Chackes, who specializes in BFRBs, and I'm going to let her tell you a little bit about what that is and why it's important that we know about this and that parents know about this for teens.
Yes, thank you so much for having me. And so, I'm a psychologist in St. Louis, Missouri, and I own the Center for Mindfulness and CBT, which is a group practice where we specialize in anxiety, OCD, and these body-focused repetitive behaviors that I'll be talking about today. And so, in short, BFRB stands for that body-focused repetitive behavior. So the most common types of this are skin picking and hair pulling. So you may have, learned, if you're a therapist, you probably had like one little tiny mention of it in grad school, probably trichotillomania. That's what you've heard, the hair pulling. Then they also call skin picking dermatillomania, or it's now in the DSM as excoriation disorder. So these behaviors are basically characterized by compulsive behaviors that basically, they can't stop. So teens that are doing these behaviors most often desperately want to stop doing them, but it's almost like an addiction in that they really cannot stop. It's much more than a bad habit. It's something that is, a psychological disorder, and it is categorized under OCD related disorders, and there's some similarities with OCD, that kind of compulsiveness of it, but it actually is pretty different from OCD in that OCD is generally fear-based, and this is generally not fear-based. It's generally, I think of it as more self-soothing than anything else. Like, think of like thumb sucking in a child. That is normal when you're young, but if you continue to do that, that would actually be a BFRB, because it would be causing some harm to your teeth or your thumb if you continue sucking. So nail biting is another common one, which we don't really see for treatment very often because it's more normalized. It's people that bite their nails. There's no stigma, there's usually no shame or very little shame, so we don't see them as much in therapy. But nail biting could be a BFRB as well. So just that repetitive behavior that causes damage to the skin or hair, and that people want to stop, but they're unable to do so.
Okay. I have a question for you, because I think you had kind of laid the ground for this. I think that there are a lot of behaviors that are normalized, right? Like, chewing your cuticles, picking your nails, all those things feel very normal. What is kind of, I guess, the scale you look for when we're talking about like normal, typical behavior versus like something that would qualify for a body-focused repetitive behavior?
Yeah, so that's a great question. It's, really mainly if it's causing the person a lot of distress, and that distress might be embarrassment, shame about the behavior, or frustration that they can't stop. Or if it's taking up a lot of time, so it's making them late to things because they can't stop the behavior, or if it's causing a lot of physical damage. So, like you said, even like pimple popping, we all do that to some extent, or the hair pulling. Yeah, if we have unwanted, hair, eyebrow hairs, or gray hairs, we pull them out. So yes, we all engage in some of these behaviors because they're actually mostly normal grooming behaviors that have just kind of gotten out of control, or kind of doing it way too much to where it causes harm. So the people that we see in therapy, or the people that really need therapy, are ones that are just really distressed by it. It's disrupting their functioning in some way, or causing significant damage to their skin or hair. So like with the hair, you might see like bald spots or missing eyebrows or eyelashes. However, I will say people with BFRBs go to great lengths to hide the behavior. So often you won't see it, and so unless you ask, and I really do recommend all therapists ask, just say a simple question like, Do you ever struggle with picking your skin or pulling your hair, doing other behavior over and over and being unable to stop? Just a simple question like that. And if they do say yes, then you can get into more detail about what's the behavior, how often are you doing it, what kind of harm is it causing you. Because most people will not bring this up, and I've even had in my practice, my other specialty is OCD, and I've had people where I've seen, for OCD, before I started routinely asking about BFRBs, I had someone I had seen for like 5 years before she finally said, actually, she saw a flyer in my waiting room about a group I was running for BFRBs, and she said, actually, I do that skin picking, and I felt bad that I had never even asked her about it. So yeah, it definitely is hidden by, makeup, clothing, hair pieces, tattooed eyebrows, fake eyelashes. There's obviously lots of ways to hide the behavior. So often you won't see it unless you ask.
Well, I think that's like such an important point, because I do feel like, particularly with teenagers, there are sometimes a lot of teens who like don't understand that what they're doing or engaging in is actually considered BFRB or self-harm or something like that, and they're looking at it and being like, oh, like there are more people that do this.
Exactly. Yeah, that's why it's so important as therapists and as parents to identify these things, because yeah, often they don't even realize that what they're doing is something that anyone else does. So there's so much shame about it because they think, gosh, I must be so weird. I'm the only person that does this. Now, social media has definitely helped. So if if they've Googled it or if they've gone on social media and found connections to other people, that can definitely help. And, but yeah, there's still, I think, some teens that really don't know that it's a disorder. So we can help them tremendously just by asking those questions and then saying, well, you know what, this is a psychological disorder. It's not your fault that you're doing this. You're not the only one, and treatment is available. So that, just identifying it and naming it, is one of the most therapeutic, steps you can take as a therapist or parent, really.
Well, and I think part of that is like being seen and having words, right, for what they're experiencing is like such a huge deal. And I want to go back to, because you kind of mentioned like shame a few times, and I think that oftentimes, if we're not asking, right, and we're not like really pushing for that assessment early and often in treatment, right, like not every time, but like, when I'm working with a teenager, I like to do kind of like a quarterly update, we'll say, about like behaviors and different things that they like may have happened that they didn't focus on in therapy, or that they didn't feel comfortable bringing up, because it gives them like a lens to do that. But I guess I'm kind of curious, like, I think that there are a lot of therapists that would shy away from being really direct about like asking that in assessment. And I'm curious if there is a benefit of being softer or gentler, or if it really is just being like, here's the question I'm going to ask you. And them just having the confidence to be like, this is the question.
I do think being more direct is best, because if we're dancing around it, the client may not get what you're asking, and they may be missed. But also, I think that could create more shame, because if as a therapist you're like acting like it's kind of weird, I don't want to say this, and kind of like how we are with suicide. And yeah, the recommendation is just be blunt and just directly ask. And I think it's the same for this. Yeah, I know that parents often worry, but therapists too. Like, if I say this, I might be putting an idea in a kid's head. That doesn't really happen. I mean, I don't, if a teenager is not doing the behavior, they're not going to hear that and be like, ooh, I want to do that. I mean, we're not glamorizing it. We're just asking a question. Just, do you do this? And just like we ask a lot of other questions in our intake. And I love that idea of quarterly check-ins. Actually, that's a great idea, because maybe they didn't feel comfortable admitting to this behavior at first, or maybe even it started up, more recently. So that's a great idea to kind of do a re-intake every quarter.
Yeah. And it's just, I send out a form in my EHR, and a really quick, just like, I have check boxes for things that like maybe haven't come up that they like want to talk more about, and then also have like additional spaces where it's like, has anything happened in the past couple months that we haven't talked about that's like currently impacting you, right? Like the way that I've worded it really allows them to put anything in there they feel like they want to. And I always ask in those two, like if there's any changes in like gender identity or presentation or sexuality that they like maybe haven't wanted to talk about yet, because teens change a lot, right? Like when you get someone at intake who's 12, 13 years old, by the time they're 15, they've gone through several different iterations of themselves, right? They've tried a lot of behavior. They've explored a lot of different things to see how that feels for them. And so I think it's really helpful for us to be like, hey, like every 3 months, I'm going to ask you some questions and you're going to let me know if we're on the right track. And like, you know, it's like that reassessment, but it's not 17 pages long.
Right. I like the checkbox idea for this because I think if you just put in there, like, you could just be one line that says, like, excessive skin picking, hair pulling, or other repetitive behavior, or something like that, and they could just check it off. Because beyond the skin picking, hair pulling, like you mentioned, the cuticle, that's another big one that can get out of hand if there's infections, or sometimes people don't feel like comfortable getting their nails done then, and then they feel like they're kind of left out from their friends who are all getting their nails done. Another common one is cheek biting. So again, we can't see this, but they're kind of biting their cheek, lip biting or lip picking. So there's so many different versions. But I think the skin picking or hair pulling, if you kind of mention those two, then if someone's doing one of the others, hopefully they'll realize they're similar.
Yes, yes. Well, and I think too, like going back to what you had said about like a clinician asking this in intake, I think that it's part of our responsibility in session to like to decompress the shame, right? And if we are not comfortable asking some of those questions and we're not comfortable being really direct and to the point, I think you're absolutely right that I think it probably further perseverates the shame that person is feeling, and it's going to make them feel less like they want to open up and share. Because I often also feel like, this is not to shame parents, but I think sometimes when parents find out, they have this really strong, big reaction out of worry, concern, but it comes across sometimes in a shaming or guilt way, and it further shuts down, particularly the teenagers.
Yes, yeah, that's a really good point, and that's what I would also really emphasize for the parents is you do want to be direct, but you also don't want to make it a huge deal. You just want to be curious about it. So, and try to understand how it's affecting the teen. It may be that it's kind of minor, mild symptoms and it's not affecting them that much, or it may be a bigger deal to them. But either way, I think, the parents, it's best to take the approach of just, kind curiosity and just offering support. Like, how can I help you with this? Or I guess first, do you want my help with this? And then if so, how can I help you? But I mean, one thing I can tell you for sure is that telling them to stop is not going to help at all. All that's going to do is make them, just completely, withdraw from you or just hide the behavior. And it's completely natural. I'll even say, I have a teen daughter. She doesn't, I don't think it is a BFRB, but occasionally I see her picking at her lips, and my instinct is stop doing that, don't, especially because I'm like worried it's going to turn into a BFRB. But then I realize, okay, no, that's not helpful to say stop, because all it does is, we know it's telling people to stop a behavior just gets them more defensive or secretive about it. So it seems obvious, but still, that's what most parents go to is. And parents, if you've done that, slipped up like I have, that's okay. You could even just apologize to your teen and say, hey, I'm sorry I told you to stop. I know you can't just stop. Obviously, if you could have stopped, you would have stopped, and I want to support you. So is there anything I can do to help? I think that's just how to start the conversation.
Absolutely. Well, and I think it is about like being curious and asking lots of questions. And I think like probably similar to you, where in order for us to truly understand how to like treatment plan or how to like offer different skills and supports, we really have to understand the behavior. And so by just telling them to stop, it's not really giving us an opportunity to ask all those great questions. And then they're probably not going to be as open in talking about it. So I'm curious, when we talk about BFRBs, right? And we're talking about, teens who like might need treatment, teens who might feel like a lot of shame around it. How do you go about suggesting, parents get their kids into treatment, or what are they looking for in a therapist that can do that? Because I know there's lots of great therapists, but I know there's also therapists that specialize in BFRBs. And so I'm curious if you have suggestions on maybe what to look for, how to look, or any of that if you're a parent looking for treatment.
Yeah, it is difficult because there aren't enough, therapists trained in these disorders. So if you're a therapist listening to this, I would definitely say, and if you're looking for a specialty area, this is a great one to get into because there are just not enough therapists. But I think generally looking for, first you can search for, BFRB, use that term, BFRB therapist. If you don't find any in your area, looking for an OCD therapist or an anxiety disorder specialist, as they may have at least some knowledge or some understanding of the behaviors. If not, and there are definitely, areas where there's just no BFRB specialists or anyone that knows about it, I think you can, as a parent, educate them, even, say, here, I'll buy you this book, I have a book, I personally recently wrote a book about for teens and young adults, and I think that would be great as a resource for the therapist too. So you could, if you can't find one that specializes, at least give them some, guidance and training. And yeah, sometimes a book, and just go through the book step by step. If the therapist is open to learning and doing that, I think that would help them then be able to treat other clients with it.
Yeah. I totally agree with you. I don't think that there are enough folks that really love this work, that dig in and like wanna provide great treatment. And I think it's kind of like an unknown area in certain ways. And I'm curious because I wanted to ask you this in the beginning. When did kind of like trichotillomania and all that stuff start becoming body focused repetitive behaviors? Like, when was that more of a thing? Because I was in grad school in 2010, I want to say, and we didn't really talk about BFRBs.
Yeah, so no, that's a great question. So trichotillomania has been in for a long time, I think since like DSM-3. But it used to be under impulse control and other disorders, and it was just trichotillomania, which is the hair pulling disorder. So then it wasn't until 2013 with the DSM-5 that skin picking got in, and they moved them both to, so that's when the body focused repetitive behaviors term, and then they put the skin picking and hair pulling as part of the OCD related disorders. And so, yeah, it's been not very long since it's been in the DSM, but also I think still you're right. It's just they're very under-recognized. I think that's partially due to the shame and embarrassment that a lot of people aren't seeking treatment, and I think that the researchers aren't doing enough, to research like effective treatment or even medication. We don't have any FDA approved medications for these disorders. For some reason, they've really become under recognized, and which is part of what grew me to become passionate about treating these disorders, because I was just treating OCD and started seeing more and more people with hair pulling and skin picking. And this was about 20 years ago, so before skin picking was even a diagnosis. And I guess once I realized that how few providers there are, how little there is known about this, I just kind of felt like, well, that's not fair to these people that have this disorder. So I really realized that like spreading awareness is what was needed. I do still think that's what's so needed for the scientific community, the therapist community, the teens themselves, the parents, teachers, doctors. Even pediatricians they again, kind of like us, they probably heard about it briefly, but they're not really recognizing it very often. So it is newer, but also just, under recognized. And these disorders, the research is showing like 1 in 20 people have a BFRB. So that's pretty, more common than a lot of the disorders that get a lot more attention.
Okay, so I had a guest on the show a couple months back talking about chronic illness, and I had asked her what she thought it would take to be a really good clinician for people that were working with chronic illness. And I'm actually curious if you have an answer to that with BFRBs, and just understanding like what it takes in terms of like your kind of like clinical lens, or like your consistency, anything you think would be helpful for people to know about like what it would take to be good at this.
Yeah, that is a great question. And I mean, I would say that someone who's open to learning and just, wanting to support people. So that's probably all of us, right? But I guess, I mean, I originally, and I still say I am like a CBT therapist, but I don't think you have to be fully CBT. I've actually started then incorporating a lot more mindfulness and self-compassion. So I think, anyone that uses any of those approaches, we also do use some DBT approaches, some ACT approaches. So it kind of combines a lot of different approaches. So I really think any therapist could really be a good fit, just someone who's open to learning and just who wants to kind of help that underserved population, maybe people who are just passionate about, treating those people that haven't been able to get services in the past or just haven't, known the services existed. So, I mean, I've heard, I don't know, there are some things that you might hear a teen say that's kind of like gross. And I think I've heard in my training too, like, we have to kind of almost expose ourselves to, like, I don't know, like some of the things that I thought were, like, for me hardest to hear is if somebody was talking about like picking at their toenails and then even like pulling a toenail off. And to me at first I was like, oh, like, so you almost have to do like exposure therapy for yourself, like saying that over and over or hearing it so that when the client says it, you don't make a face. Because even a subtle like gross, I mean, if your face is like, ooh, that sounds painful, that's okay. But we don't want to like portray that we think it's gross, even though, I mean, some of it kind of does sound, it's sometimes hard to hear. But I think if you're willing to learn and open to, learning those treatments, that anyone could be a great fit for this population.
It's interesting because I feel like when I was in my first job out of grad school, I was working community mental health, and I feel like for the most part, all of us that were there were kind of like, we're gonna get assigned whatever cases we're gonna get assigned, and we are gonna figure it out, right? And so like we had really great supervisors, and like for the most part, we had really lovely teams, even though it was community mental health. I learned so much from my team members, but it's interesting. The more we've gone on from like my initial experience, I feel like there are a lot of people, clinicians, who are like, oh, like that's outside my scope, or like I don't have training for that, or like there seems to be this like hesitation or fear in taking something on that you maybe haven't worked with before. And so I'm curious on your thoughts in terms of like if you are a newer clinician or you're a clinician who's never worked with this before, and you end up with someone in your office who is like, this is a thing that for me that I'm really struggling with. What do you recommend they do from that point on?
Yeah,
Aside from giving the client to somebody else.
yeah, that is a great question. And like I agree to it to some extent. Like you can't be a specialist in everything. However, it is good for us to all understand at least how to recognize and diagnose and at least, kind of start the treatment with all disorders that we might see. So, I mean, I would say just, starting with this like curiosity and self-compassion work is really kind of the start of it, because what we've really found is that like there are a lot of good CBT techniques, and there's even an evidence-based approach, a comprehensive behavioral treatment for BFRBs, and it is a great approach. But until you can kind of give them some self-compassion tools to be able to not be beating themselves up so much, the treatment we find doesn't really work as well. So I think just starting with like normalizing it for the teen, like this is actually pretty common, and a lot of people don't even talk about it. So you're really brave to bring it up in here, and then just starting to just be curious as a therapist about what's going on for them, because a lot of it is understanding the function of the behavior, because it can serve different functions for different people. So I had mentioned self-soothing, that's one of the most common things, but it also can be stimulating. So a lot of people will do these behaviors when they're trying to focus on schoolwork or just on their phone or watching a TV or something, or driving or being a passenger in a car, kind of like bored. Times when you're bored, you might start doing the behavior to kind of wake you up a little, stimulate you. So it can be soothing. It can also be stimulating. It can be, used in a way to like help reduce anxiety or, frustration, sadness, emotions like that. So you really gear the treatment towards whatever you find out is the function. And actually there could be multiple functions within the same person. So, and it's just like, okay, if it's, they need more emotion regulation, then you go tap into those skills. If they need, if it's their thinking that's triggering them, you need to do more cognitive work. But I always start with mindfulness and self-compassion, really. I think that it's because the mindfulness too is really helpful with awareness. I forgot to mention that too. Many people do these behaviors without realizing they're doing it. So that's kind of one of the main differences between BFRBs and self-harm, is that with self-harm, usually they are aware that they're doing the behavior, and with BFRBs, often they're not. They could be, driving and they're just pulling, not realizing, doing homework and they're picking and, don't realize that they're doing it. Mindfulness can really help with that awareness. So I think starting with that is good. And then, I hate to give a plug for my book, but I do think I have a book, but there's also other books out there. But I have a teen workbook for BFRBs that is directed for the teen to use. But for therapists wanted to just get the book, that's really honestly the cheapest way to get started too, because I do have an online course that goes through, it's like a 5-hour training, so that takes more time and is more expensive. You're welcome to definitely do that if you're wanting to get, I'd say if you're wanting to be like a BFRB specialist, you really want to get more clients with these disorders. But if you just have one client, I'd say work through the workbook. And that goes through the mindfulness, self-compassion. The support system is also huge. You'll be a support as the therapist, but helping them find others in their lives who can support them through this process, because it's difficult.
Yeah. Well, I going back to what you had said, like I could totally see this being like a self-soothing habit, and that it's not something like the same thing with addiction. Like we're not just going to tell someone to stop, right? Like there's so many little pieces that have to get put into place before we're going to really make an impact on like any sort of behavior. And I do think that there's a lot of therapists and a lot of parents and other folks in the community get that frustrated when they're like, stop doing it, you're destroying your face, you're whatever. And like the client, I feel like often is like obviously acutely aware of like other people's perceptions of like their picking or their like whatever the thing is. And so it's really hard. And I'm glad we're talking about like how do we support this population? And if you're a clinician that doesn't have any training, how do you get that, right? Do you do any sort of consultation with people?
That's a great question. Not currently. I am already like, I feel like spread too thin, but that is a good idea to set something up like that. So one thing that I'm also working on, so my husband actually recently started a nonprofit organization for BFRB, people with BFRBs. It's called the BFRB Foundation. And in there we're compiling, and I'm the so he's not a clinician, so he's doing like kind of the business or the website design and all that, compiling resources. But I am the chief clinical advisor for that foundation. And what I'm thinking of that you said would be a great idea, because we're listing all the different providers as well as support groups. I would like to find some people that do consultations and add them. I just feel like right now I don't have the capacity to do that, but I'm sure there are people that are. So that's another great category to add in there as far as resources. I do have a Facebook group and I moderate that, so I'll occasionally kind of pop in there with answers. But there's also a lot of therapists in there as well as parents and adults with BFRBs. And that's just called Overcoming Skin Picking and Hair Pulling, Help for BFRBs is the name of the Facebook group. So that's the closest I guess I provide to consultation. I will pop in and answer questions in there, but not really like, one-on-one consultation at this point.
I think, and maybe this is just because of where like I'm at and kind of how I operate, but I feel like consultation with someone who specializes in that can be such an incredible support. And even if it's not with you, like I just think like I would encourage people to like routinely get consultations on different things that they're struggling with in their clinical work. It is so wonderful to get different lenses and different questions and different points of reference, right? Like sometimes I'm sitting with someone and they ask these really profound questions and I'm just like, I love that question so much, and yet I would never have thought about that on my own. Because like every person's treatment, every way that we do treatment is different, and it's based on us and how we think and what our decision-making framework is. And so I very strongly feel like consultation is such an excellent way to kind of encourage deep work and to encourage like the specialization. And so I really feel like part of it's like get the workbook, right? Like make sure that's part of your intake packet and that you're asking that question in assessments, and that you're following up, kind of like as treatment goes. And that you're taking courses, right? Like this is the stuff that I love because like I am that person where it's like I would love to do some niche special trainings that are really focused on these like micro, like not micro because I know it affects a lot of people, but these smaller populations of people where it's like, who else does this, right? Like that's the stuff that's really exciting for me. I'm less interested in like CBT for anxiety.
Right. No, I hear you. That's how I am too. And I will also tell you that I feel this is the most rewarding population to work with. And I think that's for a few reasons. I mean, one is they do tend to be like perfectionists and people pleasers. And what that brings is somewhat of a, like they're very compliant with treatment often, they try hard to be, but they're also so grateful and tend to be like, you really get that expression. I mean, I see this more probably the older teens and young adults, but like that, just like, wow, thank you so much for even recognizing this. And like you said, like, finally feel seen. People will say that. And it's so heartwarming to hear that. The other thing I think is big is groups for this population. So either like support groups, which is another thing we're having on the foundation's website. That's already up as a list of all the support groups. There are some for teens, some for parents, and then if there's no support group or that you're nervous to do that, find your own like kind of little group, even if it's just you and like two friends that you could kind of check in with. I think for the accountability and just to have some support. But it's best if you can get a peer support group of other people going through this.
Okay. I was going to ask about the group situation because I feel like groups are challenging for people to fill anyway. But I think when there's a market for lots of different things, but I think when you're offering something very specific for a very specific population that really offers some outcomes, it's a maybe easier group to fill.
I do think so. We struggle so I own a group practice. I think I said that already, but we do struggle to fill teen groups in general, but BFRB groups, like you said, because it's so specialized, often they're really desperate for some help and to meet others with the disorder. So we have had more success in filling those groups. And we've been doing our groups online. That's kind of controversial, or, I don't know. I could kind of go both ways. I do think in person can be better, but I think sometimes the teens just feel a little bit more comfortable having that barrier, like they can kind of, put a filter on or, hide themselves a little bit with the screen because it's hard to show up and talk about these things. But yeah, I do think for a therapist-led group, I think is awesome. I do the therapist-led groups here in St. Louis, and it's really beneficial to the clients.
Yeah, that's the thing. Like I have tried to get groups up and running and they've been really hard, but I also feel like it's one of the things that I just wish people could believe in more, because I do think that like being around peers that are struggling with something similar and being in a group environment, like it allows for such a different, profound perspective sometimes. And like, I hate the fact that people are like, I don't want to do a group. That sounds stupid. And I'm just like, but just try. Like, give it like 5 sessions. And if you hate it, you don't have to go back. But
I know it is so hard. I think, yeah, if they're maybe get the parents in on an incentive plan for the group, and yeah, like you said, just give it a try, just go a few times. And often I think, yeah, that relief will come even in that first session of like, wow, okay, this person is just like me, and yeah, now I feel less weird and less alone.
Yeah, yeah, for sure. Um, you had brought up groups, and I wanted to go back for a second on the self-harm part.
Oh, yeah.
Because when we had met at the conference, I love the fact that you were differentiating between self-harm and body-focused repetitive behavior. But I'm also curious if there is a time that those two things overlap.
Yes, yes. So they definitely, there's a lot of similarities between the two because both can be used as like a emotional regulation tool, you know. So um, I guess one of this kind of speaks to the difference and the similarity. As you know, for self harm, it's going to be generally more purposeful, kind of like intent to cause harm to reduce an emotional discomfort or feeling that they don't want to sit with. Whereas with the BFRB, it's not as much to cause harm. The intent isn't to cause the pain or harm. The intent is to more like either distract or like I said, soothe, self-soothe. They generally like it feels good, but both can serve that purpose of regulating emotions, and that's a really powerful, you know, function of these behaviors. And we do see people that do both, you know. So the main difference might be, you know, so maybe they're picking at their skin and that they're doing that kind of like mindlessly, and then at times they are cutting or even more purposely like scratching to try to cause harm as a way of regulating emotion. So they definitely can overlap. But yeah, most people with BFRBs, it's really not self-harm in the way we normally think of self-harm, even though it does cause harm. It's just more of of a soothing kind of behavior.
Okay, question. Could self-harm be considered soothing in the same way? Because I often, because I specialize in self-harm, and a lot of the folks I work with, they don't necessarily talk about it in pain terms. They talk about it in like soothing terms. And so it's really interesting because I'm like, if you look at it from our perspective, there's obviously a difference between the behaviors. But now I'm thinking about it, I'm like, but from their perspective, like, would they designate that as something that is harm, or is it self-soothing?
No, that's a great question. And so I think because I don't specialize in self-harm, like it's great to talk to you and hear what language the teens who are self-harming use. And so maybe it is, yeah, more similar than we think. Yeah, I think though that either way, like whether it's self-harm or whether we consider it self-harm or a BFRB, I'd also use whatever the teen is more comfortable using. If they want to call it self-harm, I'm not going to say it's not self-harm and we're not going to use that term. If that's what the term they want to use and it's working for them, then use it. Yeah, that's fine. And also I think the main treatment of just, you know, emotion regulation, understanding the function, like why they're doing the behavior and trying to meet that need in another way. I mean, the treatment is very similar.
Yeah, I totally agree. And that's why I was so excited to have this conversation with you, because I'm just like, they are presented, I think, very differently. And it's so interesting because then, like, I think when I'm working with someone who's self-harming, I spend time asking them, like, what do they want to call it, right? And how are we referring to this in treatment? And like what does that kind of look like for them? And it's interesting because I'm like, I wonder how many of them, if they had other language, would be like, oh yeah, it's more of like a repetitive behavior or self. Like, I'm so curious now to be like, what would that look like for them? And then I'm also wondering how many people potentially with like some body focused repetitive behavior stuff would identify it as self-harm, and maybe that's a very small percentage of the whole population. But it's interesting because when I was a younger clinician, we were often told that they were the same thing, different presentations, but same thing. And so when you said that, I want to pick your brain because I have so many questions about how that presents.
Yeah, I think you're right. I mean, no, we do see some that call it self-harm. And like I said, I mean, I may like differentiate a little bit, explain, kind of this is the typical presentation of self-harm. This is typical for BFRB. But if they still want to call it self-harm, or that's, yeah, what they consider, because they are, yeah, harming themselves, there's, yeah, there's no harm, I guess, in calling it self-harm. Yeah, whatever they want to call it. It is, I think I'm learning, yeah, there are differences, but there are also a lot of similarities. And so I guess in that regard, anyone who's already treating self-harm, or just, treating teens and seeing a lot of self-harm, this would be a kind of natural progression, or, a similar type of treatment for you, because you're already doing a lot of the same stuff.
It's so, and that's the interesting part is I do think that if we go back to the shame part, right? Like that's one thing that I spend a lot of time working with in session, because I'm like, we're not going to shame the behavior that's helping you cope, right? Um, and I think that's a huge piece. And I think that it's so interesting to take both narratives, right? And I feel like they likely serve different purposes for different people, right? Either in terms of opening them up from shame, or kind of like almost like soothing this like perfectionist part where it's like, okay, like I can't control it and I'm working on this, right? And I can't just stop. So it's very interesting to me how like even like the narrative and the perspective shift in that might incorporate itself into treatment.
Yeah, yeah. I mean, one other thing I'm thinking, I don't know, like with self-harm, I would guess that the goal is for them to completely stop self-harming, where I guess maybe that's not as common as, I don't know, but with BFRBs, it's definitely, I'd say it's very, very, very unlikely to completely stop the behavior. So, like, to be in what we call in recovery with your BFRB is more like you're still doing the behavior some, but you can manage it. And it's not stopping you from living your life. So even if you did have missing eyebrows, you could just either go out like that, or put on your makeup and go out. And that when you're picking or pulling, you notice it more, you're able to manage it, and really manage the shame, manage the be able to not let the shame, because that's what I think causes the most distress and disruption in functioning. It sounds like you're saying that's similar for self-harm. So they really are similar. And but yeah, I think it's important for people to understand the goal is not to completely stop the behavior, just to like learn to live with it, to manage it, and reduce the effects, the negative effects in your life.
So that's I think one of the biggest misconceptions of working with self harm, and I think it puts a lot of pressure on the clinician to be like, well, I have to get this to stop cutting. But like the more research we have on self harm, the more we see that it actually starts way before we see like physical first injury, and it actually goes way after people would identify as like being helped or being in treatment. And so like when you think about addiction, substances, all those things, like we have those kind of like pop out behaviors where it's like, oh, I slipped up, I self-harmed, I did this thing, I whatever. And it's so much about learning from the relapse, right? And so like when I'm working with parents, or other clinicians, I'm like, it's really not about like us getting them to stop. It's about helping them understand and manage the behavior so it's not life impacting, right? Which I
Exactly.
love that you're basically saying the same thing, because I'm like,
Yeah.
oh, like, very, very similar in that work.
That's awesome. Yeah. That is, yeah, good to hear. So I think, yeah, any person who's treating self-harm, yeah, this is not going to be a very big jump for you.
I do think though it takes I love that you pointed out kind of like the managing the shock, right? And like really like doing some exposure work as a therapist to like what the potential things you could hear in session, because I do think that's a huge part of like managing your face, right? And like making sure that you're not inadvertently introducing or creating more shame and
Right.
someone who already kind of carries that. So
Definitely.
man, Laura, I have loved talking to you today, and I'm like
Yeah.
so appreciative for you to be here to have that conversation. And I think that like I hope the audience learned more about BFRBs, and like we'll link everything below for you guys. So if you want to join the Facebook group, get her workbook, and then for those of you who are in Therapists with Teens, we're going to do an entire month focus on BFRBs led by Laura. So I'm so excited to have you for that, and obviously so blessed that you were able to come to the podcast today and chat about this, because again, I think it's an underserved population, and I'm glad we could kind of talk about it, because I was like, there must be a little bit of gray overlap here. Definitely. But it sounds like it's very similar. But I'd love to pick your brain on this. So thank you so much.
So I'm excited, to have more conversations, and thank you so much for having me today.
Yes, of course.
Okay.
All right, everybody. I'm going to drop everything below so that way you can connect with Laura, buy the book, get the trainings. The 5-hour course actually sounds amazing. So we'll drop that below too. But then hopefully if you are part of the group, we will see you in June.
Yes. Awesome. Thank you so much.
Thanks, guys.